Welcome to LOCATR Concurrent Review Module, a clinical conversation. My name is Carla Licio, Director of Healthcare Reform Consultation at Center on Addiction and Managed Care Technical Assistance Center. This webinar will address the importance of LOCATR Concurrent Review. This is a wonderful opportunity to hear directly from two plan medical directors and the OASAS Chief Medical Officer about the critical use of LOCATR Concurrent Review in clinical care. With me today, we have Marc Manseau, Chief Medical Officer of New York State Office of Alcoholism and Substance Abuse Services, Pat Lincourt, Associate Commissioner of OASAS, Dr. Phil Gianelli, Medical Director at Beacon Health Options, and Dr. Neeta Kher, Senior Behavioral Health Medical Director at Optum Health. Pat, I'm going to turn it over to you to start us off.
Thanks, and welcome, everybody. We're really excited to be here to have a conversation with medical directors who've had experience with concurrent review from a plan perspective, and our brand new OASAS Chief Medical Officer to talk about this really crucial, I think, conversation for right now. We are making sure that people are aware of our concurrent review module. It's been out for about a year. Plans and providers are having conversations with this concurrent review module. It's really important to know that the provider has a responsibility to ensure that people are admitted to the right level of care and that there's a continued stay review at some point to determine whether or not that person is in the correct level of care for and if there's a need for an alternative level of care. It's really important that you understand how the logic works in the concurrent review module so that you can explain and document the reasons for your decision-making. The tool can support that decision. You are responsible for identifying the reasons that you use the tool in the way you did and answer the LOCATR questions in the way that you have. It's also important to understand that reviews, because of the legislation, you won't have a prior authorization conversation with the plan, but you should be having clinical conversations about the plan's members who are in your care to make sure that discharge planning is happening, that you have all the information you need, and that if there is a retrospective review of that case, that you furnish the information that's needed by the plan to determine that the care was medically necessary. So I'm going to turn this over for a wonderful conversation with doctors who have clinical experience as well as planned medical experience.
Thank you so much, Pat. This is Marc Manseau, the Chief Medical Officer of OASAS speaking. So when you use the concurrent review module, its purpose is both in the continued stay decisions and good care and treatment planning around clinical matters. So I just want to emphasize that it's used when a person is already in a level of care and is being reviewed for continued stay. So as Pat alluded to, even though you will not have to do a prior authorization within 14 days, the person still does have to meet medical necessity. And it's the expectation that you document that through the concurrent review LOCATR, done at least once during a detox admission, and clinically determined when it's done during a longer residential stay. And also that you're having conversations with the plan, clinical conversations with the plan, during the time to assist with treatment planning and discharge planning. So now I want to ask Dr. Kher, how do you think about the level of care in substance use disorder treatment?
So thank you, Dr. Manseau, and I want to state that whatever I discuss here today is my opinion only and does not reflect that of Optum or anybody else. So saying that, we really want what is best for our members, and we understand that addiction is a really, severe disease with a lot of comorbidities. It has been recognized now as a chronic brain disease, which includes a lot of relapses, lapses. It's a roller coaster ride for the members and their families. So it's very important that we provide them with the necessary education and treatment that they deserve and need. Now, when we are doing a LOCATR in a concurrent setting, it is very important to remember that it is not just a cross-sectional view of the member at that point in time, that we also understand what is going on with that member that requires the member to be at that level of care. And when, a locator is discussed with us, it is also important for us to know what is going on otherwise, what is going on with the comorbidities. Are there any comorbid medical or psychiatric symptoms? If it is a withdrawal management, are there protracted withdrawals which are complicated because of other medical issues? And are those being addressed? How are the vital signs? Is SIBA or COW scores being monitored? So all that is very important because we want to think of this member from a holistic point of view, taking into consideration what is best for the member and making sure that the treatment is more individualized, as each member comes from a different aspect at that point in clinical setting, and a standard treatment may not be applicable for them at that point. So that is why we want to focus what is important for that member at that point in time without making it a cross-sectional view.
So now the logic of the locator has two fundamental questions for concurrent review. One involves medication-assisted treatment, and the second is, why does the client need 24-hour medical supervision and nursing monitoring? Within that, there are four subdomains. So there's aspects of the clinical picture related to withdrawal, medical conditions, including pregnancy, psychiatric conditions, and then the housing and the recovery environment that the person will be going to. So Dr. Gianelli, I'm wondering if I could get your thoughts about the two fundamental questions in the locator logic.
Well, absolutely. Thank you, Dr. Manseau. I also want to add that my comments and opinions are my own and do not necessarily reflect those of Beacon Health Options or anyone else for that matter. The two fundamental questions. Medication-assisted treatment at this point is standard of care, evidence-based treatment. It is fundamentally important that our patients, members who are admitted for treatment for withdrawal management, as well as other levels of care, but focusing on withdrawal management, that the role of medication-assisted treatment, medication-supported recovery is stressed, and that the conversation is had with the member patient, and that it's documented that it has been, it has been broached, and the reaction and the fact that, it really is fundamental for stabilizing our patients in their initial abstinence and recovery. We have great medication, especially for opioid use disorders, in the form of buprenorphine, naltrexone as Vivitrol, injectable, and not to be neglected or forgotten, methadone, which really is a gold standard for medication-assisted treatment and has been for decades. So the second question, again, the documentation, which will be coming up as a recurrent theme in our reviews, is fundamental on was MAT offered and what was the response and was it revisited. The second question, why does this client need a 24-hour medical supervision or nursing level of care? Do they need monitoring? What are the withdrawal signs and symptoms? As Dr. Kher said, do we have COWs? Do we have a CWA where indicated and appropriate? Do we have documentation of vital signs? And especially the vital signs and COWs and CWA in response to medication for withdrawal management. Any medical, extraordinarily important, pregnancy, other issues with pregnancy for our female patients and members, any other medical co-occurring disorders that need to be identified and stressed. There are some foci now for including medical management in some of the OASAS facilities, which would be wonderful. Psychiatric comorbidity, which again is tremendous, 50% or more of our patients coming in for withdrawal management will require assessment and management of psychiatric co-occurring disorders. And again, finally, housing and recovery environment. If the member is coming in and has difficulty maintaining sobriety and recovery in the community, we need to look at the holistic, as Dr. Kher said, holistic picture. And what is the recovery environment? and how supportive is that environment, and especially now that we have a wonderful array of treatment services in the residential redesign, the 820 levels of care. Thank you.
Thank you so much, Dr. Gianelli. I want to sort of quickly double back on pregnancy. It's a particularly sensitive time, and especially for women who are pregnant with opioid use disorder, we really want to emphasize that the standard of care is medication-assisted treatment, and they may need an inpatient environment. They probably need an inpatient environment to successfully transition to that. And I also want to just mention that withdrawal, if the medications that you're using in the setting are preventing withdrawal from getting worse, and if you expect that withdrawal would worsen if the medications were tapered or withdrawn, that is a reason for that person to be in that level of care, and you should document that in the concurrent review locator. So Dr. Kher, how do you approach thinking about that risk, and what information is important for you when thinking about medical need based on the locator decision logic?
Sure. So the most important thing is to put the member first, right? We want to understand where is this member coming from, what drugs is he using, what is the mode of usage, take a multidimensional view of the member from his psychosocial determinants, is the family involved, all those kinds of things, and also understanding what kind of detox protocol has been used, because it's important to remember that treatment needs to be individualized. So for every member, it cannot be a 5 or 7 day standard detox protocol. So it's very important to remember that. And also it is important to understand that if you're doing whatever needs to be done, and if the member is still showing some symptoms, then it's important to remember that these days there are a lot of designer drugs that are available which are not detected on urine or blood screening, and which can also exacerbate withdrawal symptoms or later on cause protracted withdrawal, or also exacerbate the comorbid medical or psychiatric symptoms. So it's important to keep that in mind. The other thing also is that we have to look at the member holistically. So while they are being either in a detox setting or even a rehab setting, it is important to also kind of make sure that their medical and psychiatric comorbid symptoms are evaluated and treated appropriately. And again, it is very, very important to start all education on medication-assisted treatment from day one. Educate the member, re-educate as many times as needed, involve the family, educate them so that, we are educating the community about that. And sometimes it may not work out because of whatever is going on in that member's life or medical and psychiatric comorbidities to kind of taper completely everything to zero, but we have to work with what we have and make sure that the member is stabilized.
So now, Dr. Gianelli, can you talk a little bit about what you expect to occur during a detox day in order to help stabilize a person, such as what are the things you hope to happen during that stay with the clinical provider and the plan?
Yes, of course, thank you. And again, in echoing what Dr. Kher has said, the family involvement, the significant people in the patient's life, and early discharge planning are fundamental. And you will hear us continually refer to medication-assisted treatment, and that's not a mistake. Medication really is evidence-based treatment. It's the standard of care. It is a fundamental component of having that conversation with the member, patient, and the family. A lot of times there's pushback from the family about the use of medication as being, a crutch or not really reflecting complete recovery. So it's very, very important that client education, family involvement in education, and discharge planning, identifying the social supports and preparing the client and patient for the next steps. Again, there are a great deal of wonderful supports available, including the peer support for the SERPAs, the certified peer recovery advocates from OASAS to help and bridge the patient from the detox level of care in the setting to continue with their medication-assisted treatment on the outpatient. And again, prior to stepping down to the next level of care, that MAT really needs to be embraced, supported, and thoroughly documented that it happened. And the emphasis to continuing engagement in treatment. Again, it was stated before by Dr. Kher and Dr. Manseau, this is a chronic relapsing disease. And in that needs to be managed in a chronic relapsing disease model. Also, I want to just add that there is a great deal of support for use of medication-assisted treatment that will be alluded to later in the slides in the form of ECHO programs and PCSS.
Now, Dr. Kher, can you talk a little bit about medications for opioid use and the transition in care? I know we've already touched upon this, but there's probably a few more things you'd like to say.
Sure. So, as we have emphasized, medication-assisted treatment is the standard of care and evidence-based care, especially for opioid use disorder and alcohol use disorder. We have wonderful drugs or medications that have been approved by FDA. For opioid use disorder, we have Suboxone, which is available as an oral or sublingual preparation, as well as subcutaneous and, implant preparation, which are long-acting injectables, which also help with, compliance and maintaining sobriety. So it's very important to remember that we have methadone, which is the gold standard, and both of these medications are equally safe in pregnancy, for a safer pregnancy, taking it to term, and also for healthier deliveries and babies. So it's very important to remember that. Also, we have naltrexone, which is available in oral and, intramuscular preparation for better compliance. However, we have to remember that in opioid use disorder, we have to wait for 7 to 10 days from the last opioid dose until we can start the naltrexone. And also, it is important to remember that for providers, like Suboxone providers, ASAM has mentorship available. So, it's not like you have to do it alone. You have mentors. If you work with ASAM, you have mentors available who can guide you through this process of how do you do Suboxone induction and maintenance in your office and help educate members to maintain their sobriety. The most important thing also is that we see a lot of members being detoxed and discharged back into the community when they are using opioids, especially fentanyl and heroin and everything that is available on the streets, unfortunately. And what this does is that it decreases the tolerance to opioids, and when members are discharged and use the same amount that they were using before, unfortunately, it can result in overdose and death, which is very unfortunate and preventable. So educating clients and their families about this is also equally important. But most important is to get them on medication-assisted treatment.
Thank you, Dr. Kher. I really appreciate you making those points, that if someone does end up choosing detox, even after all the education that you provided to them about how medication-assisted treatment is their best chance of recovery, to provide a lot of education to them about the risks of that, and also to make sure that they have naloxone in their hands before they leave as well. So I want to just thank Dr. Kher, Dr. Gianelli, the Center on Addiction, and Pat Lincourt for promoting and producing this webinar, which I hope will be helpful for everyone to use the concurrent review locator, which will hopefully help you to decide on the appropriate level of care, document medical necessity as appropriate, and discharge plan for the person that you're treating. Thank you very much.